Hello, and welcome to the Canadian Story, where we discuss what Canada is, what Canada could be, and what Canada should be.
I grew up in Thunder Bay, and let me tell you, everything bad in the world was because of Toronto, right? Toronto was the great evil.
Everything bad in the world is because of Toronto.
I would agree with you, man. I would agree.
So my older sister was born in Thunder Bay. My parents lived in Thunder Bay for 3 or 4 years, and then I was actually just up in Long Lac, which is only about 3 hours outside of Thunder Bay, doing a
yeah. My brother lives there.
No way.
Yeah, you know RW Trucking. I don't know if that company's still in business. Bob, he hit the and then that's my uncle, and so he was the big trucking company up there. And then my brother Ross, he drives truck up there. He actually I think lately been working more in the mines, driving those gigantic things. But,
oh man, my brother fixes those machines. He's a heavy mechanic, so he works in Red Deer. There's a big mining kind of like operation. Well, not a mining equipment servicing operation he works at, but he loves that stuff. He's amazing. He's got 31 years old and he owns 5 doors already.
Wow.
We came from nothing, as Zach knows. So
yeah, 2 of my brothers are truckers. So Zach, what part of Thunder Bay, Northward or Southward?
Ooh, I wouldn't know. That was before my time.
Oh, okay. Because in 1970, I was born in 1970, but 1970 was when it amalgamated Port Arthur and Fort William. And so there's rivalry. Oh, you're from the south side.
I do really like it up there, though. I do. I've been to Thunder Bay a couple times. I like Thunder Bay as a place well enough, but I love us Southern Ontarians like to get caught up in this idea that all of Canada is the GTA, right? Because there's so much going on here. But you go up there and it's like a different place, and I really like it.
Yeah. I don't like their voting patterns, but there are some. And this is we're getting off track here, but talking about conservatism in Canada, I'm not sure that, I don't have words for what we thought about growing up. Like we loved what we loved. We wanted our snow machines, and we wanted to go fishing, and we wanted to be able to build a barn without having the government approve it and all this kind of stuff. And so what kind of political party is that?
That's an Albertan.
Yeah. That's right. It's like, don't bug me.
That's what that is. There you go. That's you're not. It's a people. It's a nation within a nation, as they say.
Yeah. So we're just kind of, I don't know if you call that Western populists, or basically we just didn't want much government at all. Anyway, sorry, I'm using up all your time, Zach. I don't know how long we're recording.
No, that's okay. Guys, I mean, we count things in and do like a whole introduction, but I kind of feel like we're already rolling. So Shawn,
we're already going. We're already vibing. Really hard.
So Shawn,
we keep vibing.
Shawn, officially, welcome to the Canadian Story. You are the author of this book here, When Politics Comes Before Patients: Why and How the Canadian Medicare System is Failing. An interesting topic. I just finished the book this morning. Why don't you just start, though, by telling us a little bit about yourself so that people have a background of who you are, and then we'll get into the book and what Canadian Medicare really means in Canada.
Yeah. So thanks, Zach. And I really appreciate you reading it. I'm really looking forward to hearing what you guys thought about it. So I'm just a family doc. And when I say just a family doc, it's a hard job and all the rest, and you're supposed to qualify that. But really, I'm just a rural family doc. We're rural, but not remote. Having said that, I've spent an awful lot of time in emergency medicine, and it's actually pretty hard to get people to serve in leadership roles in medicine, just because your income goes down and your headaches go up. So right from a fairly early time in medicine, when I started out in emergency medicine, I had the opportunity to become medical director in chief, and then physician leader, which is medical program director in other large hospitals, and then just go from there. And once I got involved in leadership, you get to see behind the curtain or under the sheet or whatever analogy you want to use. And you realize, holy smokes, there's this whole world around you that is controlling the environment in which you provide care. And so that's where I just, once you get a whiff of that or a taste or whatever analogy you want to use, again, there's no going back. It just consumes you. And so really I've spent probably the last 20, 25 years in medical politics and served in a bunch of roles in the Canadian Medical Association, the Ontario Medical Association. I'm now involved in a think tank out of Ottawa, the Macdonald-Laurier Institute. So just loving ideas. But I didn't start out as a political guy in high school or anything, right? I was just a science and math geek who liked doing outdoor stuff from Northern Ontario. So that's who I am. And so I really feel I'm coming at this from a student's perspective or a student's attitude, sort of a lifelong learner. A lot of people, I'm not sure what you think about Leo Strauss, but I've been getting into Leo Strauss lately. Some people hate him. They think he's the devil. Some people think he's awesome. But he makes this comment that really a commitment to philosophy is a commitment to lifelong learning, a conviction of your own ignorance. And I'm not saying that as a humble brag. I'm just saying that as a fact. And if you get into medical politics, you start reading books. I think the first line of my book was that there are no experts in medical politics. And it becomes intimidating for the rest of us. And I think we all need to be jumping on board, reading my book, reading other books, and taking part in this really fundamental debate in Canada.
Okay. So let's frame it this way. I, like most people who listen to the show, was born in Canada, right? And so you grow up, well, at least I grew up, having never thought anything else about our medical system other than it is amazing, it is free, it is world-class. We live in the best country in the world because we don't pay for medicine. Everyone gets taken care of. And then something very disruptive happened to me regarding that sort of mentality. My wife, who grew up in Los Angeles, moved to Canada and got integrated into the Canadian healthcare system and basically looked me in the face and said, "What the hell is wrong with your medicine? This is terrible. This is the worst experience I've ever had with doctors, with the whole thing. What do you mean you have to wait forever to get service? Like, what do you mean?" And I will preface that comment with, her dad worked in corporate America his entire life. They are a family who was able to afford good health care. And I'm not very nuanced on the ins and outs of what the difference between good healthcare in the States and bad healthcare in the States is. So I'm saying it with a grain of salt in the fact that I know that my wife came from a good situation, but either way, she came up here and said, there is something wrong with what's going on here. So it's an incredibly interesting and insightful book. There's a lot of information here. There's something like 700 citations. It's insane. You must have worked so hard on this. And it's going to be impossible to encapsulate all of what is in this book into an hour-ish long conversation. But let's do our best here. So why don't you take us from the start? Why are we in the situation that we're in, and what is the problem?
So great question. And I think I would summarize it with the title. It's because we're putting politics and political decisions and decisions about allocation and funding and redistribution and regulation and the latest bit of legislation ahead of patient care. So I've sat in meetings for several decades and, at the end of the agenda, what about this patient care issue? What about, the patients lined up down the hallway in our department? What are we going to do about the 44 admits that have no place to go? That's almost requires its own separate meeting when you're actually talking about how to run the system. And I'm speaking as, I served as an administrator, a bureaucrat, if you would, I'm one of the evil bureaucrats.
You're one of those guys.
That's right.
This conversation's over.
That's the title of the episode is I'm one of the evil bureaucrats.
Yeah. Hey, I just noticed the recording button ended. So did you turn? No, just kidding. Cut me off. Right.
We don't censor people on this podcast. We just don't talk to the likes of you.
Everyone is allowed to talk.
Oh no, I'll have to be careful not to say something I'll regret my mother hearing or something because she listens to these things, right? I can be careful here. But seriously, there seems to be a fundamental divide between the people people trying to provide care for patients and how we think and see the world, and how the rest of the world that's involved with running healthcare thinks, and the problems that they face. And so that's really where the book comes from. If we didn't have an hour, I would just start with a one-liner saying, we've had Medicare for 50 years. I think it's an opportunity to look at how we're doing. Are the policies and procedures and regulations and everything that we do inside Medicare, is it delivering patient-based outcome and service? And are people happy with the care they get? And to your first point there, Zach, you said about your wife, and that is so classic. There are two Medicares. There's the one that we dream about, the one that we hope will be there when we get sick. And then there's the reality that we have to face when we actually get admitted. And unfortunately, only 4% of any population in a particular catchment area needs to be admitted to acute care hospital in any given year, roughly 4%. Sometimes it's as high as 6%. So a small percentage of people. And it's usually people who are very sick. They're not necessarily super articulate. Sometimes they're demented, and maybe they've had a stroke. And so not the movers and shakers like you guys, right? And no, seriously, like you guys do podcasts, and you'll go on and you'll rattle the bushes and go to see your MPP and your MP, and you write letters to the editor. Those aren't the people getting admitted to hospital. And so the reality of Medicare is very different. So there are two Medicares. And I better stop there. You guys got to cut me off, or I'll just
no. Keep going. You're riffing hard. I want to hear more. Go.
So one of the things, and I wish I had thought of this when I was writing the book, but all of this content is in the book. But it came to me after, and actually rereading the book, I was highlighting. I was like, oh my gosh, it's all in there. There's a fundamental divide between how people think who are trying to provide care and how people think who are trying to run care. So the divide between physicians and the state, or physicians and government, or nurses and doctors and government, if you like. I don't have good labels for them. Clinicians and controllers, shall we say. So the clinician is focused on quality of care. How can we do the right thing, get the right drug to the right patient? The state is focused on payment for care. So quality versus payment. The clinician is focused on providing care for the patient who shows up on your doorstep in your emergency department. The state is focused on distribution of care, or distributing care and regulating care. Roy Romano, famous from the Romano Report, NDP premier, outspoken personality. He says, we have to fight to protect Medicare, our, quote, great redistributive system. Right? That's what matters to him. That's why he loves Medicare. Again, clinicians put priority on the sickest patients. So we're driven by prioritarianism. The state focuses on equality. How can we get the same kind of care to everybody across Ontario or Alberta or wherever you are? Clinicians focus on individuals. How can I do a great job for this person in front of me? The state focuses on populations, and the state actually gets frustrated. Doctors, how come you're not focusing on your population, your whole roster of patients? No, that's not how I think. I'm focused on you as a patient. And then finally, clinicians focus on the legal risk, right? We don't want to get sued and in major trouble and lose our license. The state focuses on political risk. Who do we have to make sure is happy so that they don't attack us in the next election campaign? So I better stop there, but it gives you a sense sort of the fundamental divide. And right now, all the authority and control is on the state side of things. And so inevitably what happens is the patient care issue, the service issue, the priority on the sickest patient, actually getting people out of the waiting room, isn't a priority on the state side of that fundamental divide.
Right. So you might say that too much authority lies with the individuals who are not actually in the emergency room handling the patients who come through. Would that be a fair assessment of and summarization of what you said there?
It would. And when I hear you say it, I think, oh, now I'm being too hard on the administrators, right? Because a lot of these people are my friends, right? And the MPs, the MPPs, primarily, provincial politicians. And it's not just that they have too much authority. It's that the way things have developed, authority has shifted to them so that they, the economists, I'll geek out on you, Edmund Burke's line, right? The sophisters, economists, and calculators, right? They're in control, and they're the ones calling the shots. And they're calling the shots because we've asked them to call the shots. We've said, hey, here's a bucket of money. You have to allocate it. And oh, by the way, you also have to make sure we have education and the courts and police keeping and all the rest. And it's an impossible job for them to do. And then we wonder why it fails. And we wonder why we don't care.
I want to dig into this. Okay,
go.
So I couldn't agree with you more. But here's a couple problems that I see that I would like an expert's thoughts on, because I'm in that 20,000 foot view world that you're talking about. That's my world, like getting people elected, helping make sure they're held accountable when they do things we don't like. I'm an organizer, right? I'm a political operative, whatever you want to call it. That's what I do. You are more on the administrative side, and you're outlining a problem that I've seen from the ministers' offices and from the purely political side so many times, is people think they understand something because they understand a little bit about it, and they have no comprehension of the totality of that thing. Just like, let's say, the centralization of economic decision-making always ends in failure because you can't know all the pieces. The market should be governing this. This is my belief. The market should be governing it. And that's why the care that Zach described in the States is better, because the market is governing it. But would there be a way to keep this, shining idea of Canadianism, which is we take care of the people that can't take care of themselves? That's like a core component of what it means to be Canadian. And that's why they love this free healthcare system that Zach was describing. But can we take that, where we're still paying for it, but somehow marketize the actual providing of it? How would that work? Is it possible? So that we could decentralize decision-making, which almost always ends up with better decisions.
Yeah. So you've asked a fantastic set of questions, and I should have been clear right up at the front. I am not trying to make a case against medical insurance. So the case for medical insurance is actually very strong, right? You don't want to run the risk of having to pay even $2,000, let alone $25,000 if you break your hip. You just don't want to do that. And so the case for medical insurance is strong. And what a lot of people forget is that 60% of Canadians were actually, now it was different by regions, but I'm speaking more for Ontario here now, but 60% of Canadians were covered by some form of medical insurance in the late 1960s when Medicare came in. And so the deal with Medicare, right, the federal government passed the Medical Care Act, and that was the final piece of the three-legged stool. We could talk about this if you want to talk about the legislation and how it led up there and how the federal government usurped control over the provinces. But anyways, so they came in, and we had Medicare, but the deal with Medicare is you had to nationalize or socialize. You had to take control of the medical insurance industry. So two large companies, for example, Associated Medical Services and Physician Services Incorporated, they both still exist, and they used to provide medical insurance in Ontario and across Canada, actually. They were put out of the business of providing medical insurance. And so now AMS does humanitarian things, educational things. PSI does research grants, and maybe some of your listeners have applied to PSI to get grants. So they're still in existence, but they're no longer allowed to provide medical insurance. So there was no rational argument or law or logic to say, no, we must have a one-size state-run medical insurance company. And that's what the decision was in 1966, and it rolled out across Canada between 68 and 72. And that gave us actually the golden years, because the early 1970s, 72 to 77, we had more beds than we knew what to do with. The average Canadian was 25 years old in the early 1960s. Average Canadian now is in their mid 40s. We had a completely different approach to life, different approach to responsibility. And so you guys got to cut me off because I'll go on forever.
Keep going.
Okay.
We're here to listen. We're here to listen to you.
Yeah, we're here to listen to you. Exactly.
No. But you got to pull me back, man. My wife listens to me and she says, "You're getting stressed. Settle down." So really, what happened was the federal government, starting in 1948 with the National Health Grants Program, usurped control, which means that they took over a provincial mandate. As you all know, in the Constitution Act, the British North America Act was its original name, Section 92, healthcare lives with the provinces. The provinces are supposed to look after that. However, the provinces didn't feel that, the political leaders in the provinces didn't feel that they had public support or voter support to start spending $1 million, figuratively, lots of money on building a healthcare system. So in 1948, federal government used its federal spending power. And this is an unresolved constitutional issue that we could geek out on as well if you want. But basically, it gives them the power to raise taxes and throw money at the provinces. We could say it nicely and say to entice the provinces to do things. I just say it's a bribe, man. It's a bribe to get the provinces to do what they wouldn't have done otherwise. So in 1940,
with their own money, I might add, because the money that they're bringing in is the taxes that they're bringing in from those particularly my province.
So now you're talking fiscal federalism and transfer payments and equalization. That's a whole discussion too. So 1948 got the provinces to build hospitals. 1957, the federal government did Hospital Insurance Diagnostic Services Act. This is the first time we see a dollar for dollar or a 50% cost sharing approach. So build the hospitals in 48, pay for care inside the hospitals in 57. 1966, pay for all medically necessary care provided by doctors. So that three-legged stool is now in place in the late 1960s. But the weird part is that from 72 to 77, we've got all these towns with, every little town had its own hospital. I mean, I'm thinking of my uncle working in Emo, Fort Francis, like 2,000 people. And there was a hospital in Emo and a hospital in Fort Francis with its own emergency department. It was just insane. And people didn't really need a ton of care because they were young. And if you had a heart attack in the early 1970s, we gave you morphine, oxygen, and told you to lie still. And that's all we could do. Whereas now we could do all sorts of things. So what happened in the 1970s is services started to go through the roof, right? We call it utilization. That's the term we use in health politics and policy. So utilization went through the roof. We could blame that on patients asking for too much. We could blame it on doctors for offering too much. Bottom line, services went way up. 1970 to 2010, there's 2.5 times more services per patient than what people got in 1970. Services going up. Inflation went through the roof in the 1970s. You all know this story. And then in 1977, the first Trudeau government passed the Established Programs and Financing Act, EPFA. And what that did is he said, no more blank checks. You guys already have your healthcare system built. You've already socialized or nationalized your health insurance programs. We're not going to pay 50%. We're going to do block grants based on a rolling average, 3-year average of GNP. We'll also give you a few tax point transfers, but really it was mostly a block grant approach. So the blank checks were done, the block grants came in, and we've been fighting about that funding ever since. So the late 1970s, the provinces started running out of money. They're like, oh my gosh, how are we going to pay for all these promises we gave the people? And that's where you get hospital user fees and so-called extra billing. We could unpack that if you want. And then that led to the 1984 Canada Health Act being passed. But really, the Canada Health Act wasn't just about outlawing or forcing the provinces to outlaw user fees and extra billing. It was actually the Trudeau government in the 15th year of his reign. Canadians were sick of him. David's smiling and nodding. So his approval rating was in the bottom, whatever, in the boots. And so he needed something to bait the Mulroney Conservatives to attack that Canadians loved. But Mulroney saw through it. And I don't know if he formally whipped the vote or he just said to his caucus, listen, guys, we got to all vote for this. And the Canada Health Act passed unanimously. Mulroney went on to win the largest majority in Canadian history that fall, 1984. And we've been shackled, handcuffed to this inability to innovate ever since. And we've been fighting over funding ever since. So that's a little bit of sort of how we got here.
Right. Thank you for that, Shawn. I think you just gave us a really good summary of where things are at. Even for someone like myself who's followed these things politically, I had not followed the development of the Health Act as much because as you know, Zach and I were kind of born into it. It was like there's a fish, they're in water. No, right? This has just always been the way that healthcare is, but it isn't. And I love what you said there at the end. We lacked the ability to innovate, right? We've lacked the ability to change because we've locked ourselves into the singular way of being. And that means that we are unable to get better care for dollars because we're locked into a system. It has to be done this way. How did we get that? Why are people still locked into that when it's becoming abundantly obvious, especially in Alberta, how bad that system is for healthcare and how broken it is, and we're not getting the results that we want. We have horrible wait times. So we have worse wait times than hundreds of other countries. Like we spend the most per capita on healthcare in Alberta. We're the top 5% in the world, I believe, and we get the bottom quartile of care. It's ridiculous. So how do we get here?
Yeah.
So why?
Yeah. So just a quick comment on wait times. A well-known civil servant said, well, we actually manage Canadian healthcare with wait times. We need wait times to be able to manage allocation of funding. But
I've read that in your book, and I was like, what?
Yeah.
Because from a patient perspective, it's like, what do you mean you want wait times? Stop with that.
Yeah. And on that same page, another person said that it's not for the patient to decide when they need care. These are basically smart people need to make the decision for you. And then you get into this weird notion about merit goods. And I forget who originally, Zach, maybe you remember the name I quoted in there. Anyways, it'll come to me a bit later if I remember it. But this concept of merit goods are things that the public wouldn't ask for unless we told you to ask for them, right? We wouldn't tell you to go out and get your prostate examined or your pap smear or your colon cancer screening check because you feel good and you don't really think you need it, and it's kind of an unpleasant test. So these merit goods are something that, no, the government needs to do for you. And so it's kind of overlapping with this whole sentiment of someone else knows more about your health than you do. And that's not to say, okay, someone knows about your physiology and someone knows how your heart works. So that's all great. But we're talking about someone knows what they should be doing to you and for you more than what you know. And for the average voter, the average patient, I disagree with that. I fundamentally disagree with that. Patients are far more informed, far more intelligent than you'd ever believe. And I'm talking about my rural patient population. A lot of them aren't formally educated. A lot of them are farmers. Brilliant people. I mean, tons of common sense. You lay something out for them and they're just like, well, doc, obviously you got to go that way. And I'm like, yeah, man, that's right. So anyway, so I'm getting off track here. David, you asked about how we're locked in. How can we change? So I tried to tackle this with a paper a couple of years back from Macdonald-Laurier Institute called Who's the Most. So in hospitals, we talk about the MRP. Who's MRP for the weekend? MRP is most responsible physician initially. And now that nurse practitioners can admit and discharge, we usually talk about most responsible provider. I hate that word provider, but anyways, there it is, MRP. So I wrote the paper saying, who's the MRP for healthcare? Most responsible politician. And so right at the core of our issue, core of our problems is we don't know who's in charge. And so I give you a concrete example. A few years ago, just to show how crazy this is, a few years ago in Saskatchewan, I believe, or no, Manitoba, it was a Manitoba provincial election. It became an issue in the provincial political campaigns over who could promise to get the best quality of toast in hospitals. Toast, as in cooked bread, put jam on it. Toast, the quality of toast. I'm just like, people, this is trampling on every governance principle you've ever heard of within an organization. You can't have the CEO or even someone above the CEO telling the cook how to cook or not cook the toast. That's insane. Or another example out east, this is from Brian Lee Crowley, shares this one in his book. They were in the midst of a labor negotiation, and I believe it was in Nova Scotia, but don't quote me on it. I think I put it in this example in the book as well, where the hospital was really taking a hard line, right? We have to be careful with our budget. Don't spend too much. Don't give these, I think it was a nursing contract they were fighting over. The provincial minister of health called the hospital CEO and said, just give it to them. One hospital, and we have the provincial minister of health calling the shots there. So more governance nonsense. When first few years in practice in the early 2000s, wrote this is when we had Smitherman, Furious George, right? George Smitherman. I love the guy, by the way. He's a very animated fellow. I don't agree with his politics, but certainly a larger than life fellow. So I hope he's not mad at me calling him Furious George, because that's what we all called him. I don't know if we called it to his face, but he would be on the radio and say,
"You did now."
Yeah, I did now. There you go. I love you, George. You're the best. Don't edit that part out, you guys. But anyways, he was bragging about how wonderful the emergency system was in Ontario and how much increased funding we gave and all this nonsense. And so I wrote a letter. Silly me, that was a big mistake. I wrote a letter to my local newspaper, which has a tiny distribution, like 10,000 people, and most people don't even read it. They just toss it out. Because I just said that, I won't tell you the title of the newspaper, but really a local community. You just look at the front page. So I wrote an article, a letter to the editor, and I said, listen, if George Smitherman, is bragging about emergency care, I want him to come down to my emergency department. And I named the name of my hospital. Big mistake. And I shouldn't have mentioned Minister Smitherman. That another big mistake. And I said, I welcome him to come down and shadow me on a shift so he can see, the lineup of ambulances that have to wait with sick and dying people. They can't get their ambulances offloaded. I want him to see all the people vomiting in the waiting room and, having their miscarriages in the toilet, in the waiting room, like major, terrible events happening. Please come down and see this. Well, the next day, Minister Smitherman, he called the CEO of our hospital and said, what the heck's going on? I just gave you a whack of funding for your cancer center. Are you telling me you don't know how to run your emergency department? The CEO called our chief of staff and the president of the medical association and our chief of department at that time. And so I was getting attacked from everybody. Shawn, what the heck's the matter with you? You can't say that. You can't mention. And so that's where I realized that our governance is completely off. The people who are supposed to be running the hospital can't run the hospital. The people who are supposedly in charge of outcomes, at the provincial level, they don't have jurisdiction. They're handcuffed by the feds. And so until we sort out that basic issue, who's on first, who's on second, who can the public hold accountable? And right now the public doesn't know. And so they just get mad at their doctors and nurses. Well, you're probably not giving me my MRI because, you'd give your brother-in-law an MRI. And anyways, I hope that sort of answers your question, David.
It does. It does.
Okay. I want to hit at a misconception that we have in our country about our healthcare too. And I want to read a quote from your book to do it. Because we talk all the time, right, about free healthcare, right? Free healthcare. So this is a direct quote from your book. It says, Canada in 2019 spent $264 billion on healthcare, or 11.6% of GDP, which is $7,068 per person. Okay. A typical Canadian family consisting of two parents and two children with an average household income of $140,000 will pay $13,311 in taxes for public health care in 2019. After adjusting for inflation, this is an increase of 65.8% since 1997. So I say that to call a spade. Free healthcare is bullshit. It's not real. Okay? So the reason I bring that up is I have no idea what health insurance plans cost in a place like the United States. But I am aware of the problems that occur when you do something like centralize. Really, maybe I could be wrong, but anything. I'm not a very large supporter of centralization, right? So if we're spending all of that money, so an average, adjusted for inflation, an average household income is spending $13,000 in taxes on healthcare. Okay, can we not craft infrastructure and localized options for health insurance that cost less than that begin to remedy some of the centralization problems? And, the government's not going to like it because they don't get to collect the tax money. But if we're dishing out almost $14,000 a year on average for healthcare, that money is taxes, right? That money comes off of our check. Why to me, it sounds responsible to do something like, okay, this centralized thing, we built this Medicare system and it is now a mess. And we acknowledge that it's a mess. So instead of trying to continue to perpetuate this mess, here's an idea. We're not going to collect X amount of tax dollars anymore. And we're going to build infrastructure or help build infrastructure to reset up privatized medical care. And we're going to do it through insurance policies. But because we believe everyone should get good care and everyone should be able to afford to get good care, we're not going to collect the tax money, but you're already used to that coming off of your paycheck. So we are going to set up a system where you pay into automatically health insurance that then goes to a more localized company that has a better bead on the geographic location that they serve, that can provide better healthcare because they are right there in it with you. To me, that sounds like at least a start. Tell me I'm wrong. Tell me I'm wrong. Why is that a bad idea? Or maybe it's a good idea, but what would be standing in the way of something like that?
So Zach, you're totally wrong because you're not allowed to make so much sense. Like that you're talking about, okay, local solutions, having payment and provider close, those decisions made locally, trying to build healthcare systems, infrastructure that will actually meet the needs of the community that it's supposedly designed to serve. Like these are rock solid concepts. I totally agree with you. And you've mentioned actually 3 or 4 examples of how things are done around the world. A couple comments. And I mentioned it earlier about the Romano types of the world. And I use his name because this is a direct quote, and I can pull the book off my shelf and read it to you if you want. But for Romano and that cohort, they don't view healthcare, medical insurance as being about providing care for patients. Zach, you do. You say, well, we have the system so that we can get care. That's what most Canadians think. They say Medicare exists so I can get care, or Medicare exists so I can get free care. For the Romanos of the world, they don't see Medicare that way. They see Medicare as our, quote, great redistributive system. And in fact, they will attack people who say, hey, why can't we improve things? There are other ways around the world. There are 28 universal healthcare systems around the world. Why can't we, learn from them and try a made in Canada approach from some of these great ideas elsewhere? They'll say, oh no, it's because you're anti-redistribution. You know what? We have to move that off the table. Let's say we love redistribution. Great. Have a universal basic income or any of the other ways you can figure out to redistribute income. You can't tie redistribution plus medical care and say that those two are the only way we're going to achieve redistribution. And I'm not saying we should have redistribution or we shouldn't have redistribution. My issue is we should have that as a separate debate. As soon as you conflate two things, it's an informal fallacy called integrating concretes along non-essentials. But as soon as you tie those two things together, and they don't have to be tied together, bad things happen. And so first step is we need to say, redistribution, great. You love redistribution, wonderful. Let's have a debate about that. Don't hijack my patient's care with your goals of redistribution. So, and that's what you've done, Zach. You've said, I'm
going to simplify this for the listener. So what Shawn just said is, don't let communism destroy your health care. That's it. Don't let the ideology of communism destroy your health care.
Yeah. So I'm too scared to say that. So I'm glad you said that, David. When Tommy Douglas got elected,
we like to say all the scary things.
Oh, you guys are bad. You must be from out west or something,
Yes. Oh, yes.
So as you know, in fact, I have a copy of Henry Sigarist's book on the Soviet healthcare system. Unfortunately, it's in the other room. If we hit pause, I could run and get it for you and show the cover. But the first thing Tommy Douglas did when he won his provincial office is to hire Henry Sigarist, who was a world-renowned expert on socialized medicine, the Soviet healthcare system. And so he learned from him and consulted from him to try to figure out how could we use these ideas in a made-in-Canada approach starting in Saskatchewan. Now, in all fairness, just because it came from the Soviets doesn't mean it's wrong. I mean, maybe the Soviets were great at growing potatoes and we can learn how to grow potatoes. So we also have to be I'm a little cautious about labels. I love labeling and saying, owning the libs or whatever, but we also have to be careful that we won't be taken seriously in the health policy community unless we actually say, okay, what particular policy idea were they trying to push? But having said that, David, you're allowed to say it. I love you for it. It's awesome. But if I said it, that's the only quote people would take.
To throw a little bit more nuance in it, let's take it away from ideological terms and just be very commonsensical and practical about this. Centralization of control in politics is called tyranny. Centralization of control in state-based ideologies is called communism. Centralization of control in the business capitalist community is called monopolies. Whenever there is a centralization of control over anything, it is bad. Decentralization allows for innovation, which problem solves much better than conformity.
Yeah, well said, man. You got I want to read your book because that's awesome.
It's being written, but it's about something very different.
I've been telling him for like a year and a half now. Like, when's your book coming out?
Yeah. No, I'll write a blurb for that, or
There we go. Awesome.
There you go. So I wanted to. So since we're getting into sort of the finances of it, I want to offer two caveats. Number one, I love the idea of having different approaches to finance, right? Don't have it just 100% tax funded. You can have a voucher system or universal basic income, or you can have direct pay by people. So let's have that debate. However, and this is my caution to those of us, I should say, who land right of center, simply reforming a payment mechanism will not necessarily lead to radical redesign. So when I go to get milk on my way home from work and I pick my daughter up, my wife says, hey, get some milk. And so I tell my daughter, run into the store, get some milk. And I want 1%, 2 bags with the 3 each. And it's got to be this price. Don't pay more than $5. So I tell her everything. I give her my Visa card. And so I've chosen the time of the purchase, the location of the purchase, the quantity of the purchase, the quality of the purchase, the particular brand, the product. I want this particular kind of milk versus that. How the strength of the product. You guys get the idea. I've made every single decision. If she gets there and my Visa is declined, or they say no, you can't use your dad's Visa, and so she uses cash instead. Well, the cash decision is minuscule compared to the decisions I've been able to make. Furthermore, that whole grocery store is regulated, and their labor relations on how many hours the people can work and when they get to take a break and how wide the conveyor belt needs to be and how often it needs to be cleaned. And there's just a massive amount of presence or influence from the regulatory state. And so simply saying, okay, we need to change the payment mechanism and everything will be golden, I would caution on that. If I was of the Romano sort of view of the world, say, okay, let's change payment, but I'm just going to regulate the heck out of this. That's been done in other countries. So be cautious there. The second caution I would say is, I started out very libertarian. The free market will save us. All we need to do is have more market. The worry I have is I've seen an awful lot of people who aren't rational agents who are able to freely contract with me when they're bleeding on the side of the road, or they've just had a stroke, or they're comatose. And so a lot of what we do in medicine, we're dealing with people in a very compromised situation. Now, with my libertarian friends or my classical liberals, they'll say, yeah, but they can make contracts beforehand, or they can get insurance beforehand, and everything will still be fine. Yes, I agree. Having said that, medicine is one of these areas where we start pushing the limits of sort of a rational, freely trading agent. For a lot of community care, absolutely. For acute care, heart transplants, it becomes difficult to envision a truly free market solution to that. And I on a podcast with some friends in the States, and they're like, oh, Shawn, you're a communist. They're calling me a communist. So I'm welcome to hear, suggestions on how we could get a purely neoliberal free market solution to heart transplants or liver transplants. I think we need a blended approach. That doesn't mean, though, that we shouldn't have decision making as close to where the decisions are made, funding following patients. I better stop there because I will totally start going down this rabbit hole of funding, and I'm not sure if that's what you guys want to talk about.
Oh, I'm very interested in funding. Here's another perspective coming from California. California has some of the highest taxes in America, right? And again, my wife grew up there. And when she moved to Canada, she was flabbergasted because she was taxed more, right? So again, those are things that you don't think about when you grow up in this environment of Canada. And I do believe that we live in one of the greatest countries in the world. And I have huge pride about the nation that I reside in. And I love this place. But every so often something comes along. Right now we're seeing a huge exodus of people from California to places like Texas and Florida, partly because of political ideology. But also we're seeing a large amount of business move out of California and into some of those other places because it's just simply expensive to operate there. And it's worse here. So having a conversation about where that money is going, I think is very, very important.
Yeah. And I wanted to dig into this a little bit because it's actually this part of the process is something I'm working on a lot with AHS. Obviously, we've had a bit of a revolution here in Alberta, let's call it, of people deciding that they didn't want to be under medical tyranny at very least, and now there's been a big push to change the way we do medicine here in Alberta. And one of the things I think a lot about is funding following the patient as opposed to it being granted to the administrators to distribute. Now that's not the same thing. I mean, that would be a heavy deregulation, right? Because we would be forcing people to compete. But I'm not really, maybe I'm a communist too, but I'm not really a fan of privatizing or even changing the funding model that we have in Canada necessarily. I just think there's and maybe this is a misperception, and I love your thoughts on this, Shawn, but I just think there is a lot of waste in the system right now, and that waste needs to be directed to the providers, or whatever we want to call them, the physicians, the clinicians. That's where the money should be. I'm not really interested in giving it to administrators or even physical. I think people need to be funded, not infrastructures and bureaucracies. But maybe I'm mistaken on that. Maybe the bureaucracies are overworked. I know they're not in Alberta. We have like 3 managers per nurse or something ridiculous like that. So, but I would love your thoughts on that, because that could be my ideology speaking more than anything else.
Yeah. So you asked for my opinion on your comment. Maybe I'm a communist too. Yeah, I think you are. Yeah. Yeah. No risk there. So
I never thought anyone was going to come on this show and call David a communist. I never saw that.
He just said he was himself.
He said he was. I mean, who knows? I'm very Canadian in this. I don't like the idea of people having, if they break a leg, to pay for it. Like I think we as a society have enough wealth of resources that we should be able to cover each other on that kind of thing. But I don't see that care happening at a reasonable dollar basis.
Yeah, no, medical insurance, the case for it is pretty solid. And that's what you're saying. Hey, I like insurance. Canadians love insurance. Apparently we love all sorts of insurance, and we can talk about insurance for a bit. So yeah, no, be strong on insurance. I don't think you're being a communist by saying you're strong on insurance. And I think it's how we structure and run that insurance, whether we have a manning care approach where you have multiple insurance programs. The label for it around the globe would be called social insurance, where it's kind of like you have to be insured to drive your car. Well, you have to be insured to be a citizen in this country. And if you can't afford to pay the premiums, the government will pay it on a means-based testing and all the rest. But at least then you have some variety. Now, having said that, again, we have to caution. The Canadian and American systems are very similar in this sense, in that the patient doesn't know how much things cost, the doctor doesn't know how much things cost, and in the States, it's the insurance companies that are really watching the costs and are micromanaging what the doctors do and what the patients can get access to. In Canada, it's the provincial health system. Now, fortunately, our provincial bureaucracies are clunky, and they actually can't pay as close attention to what I do compared to a smaller insurance company that is even more financially motivated to control what I do and what I order. So the idea of a bureaucracy controlling what's happening at the bedside is actually a very similar issue in Canada and the States. And so we can't think that simply having tons of big insurance companies will save us either. So you mentioned a whole bunch of different comments, and they're all golden. So pay for performance or pay for results, I think, is a wonderful way to drive administrations to really focus on things that we want them to accomplish. Let's say for how long people are spending in the waiting room, even a couple $100. We had the VP of our emergency medicine program, one of the largest emergency departments in Ontario, would come down every single week for an hour. Like, we never saw him before. He can't come down. No, guys, we got to how many people did we get out today? Because it's $400 if we can meet the 4-hour rule. Now, the problem is then you start to do really weird things just to meet a 4-hour marker. So you have to keep changing these incentives, but even a small amount of that funding, if it was actually tied to particular performance targets, will change behavior. So there's one idea there. The comment about paying, and Zach, you raised this, 340 billion, I think I mentioned in the book. It's now up to, or 240 billion. It's now up to $308 billion, and somewhere between 11 and 13% of our GDP. Now, the people who think we should spend more of our GDP will say, well, that's a denominator problem, right? Our GDP is shrinking. So of course it's going to be 11, 12, 13%. So don't get tied up in that too. If people start throwing that back at you and say, well, the percentage means nothing. The percentage does seem to mean something, certainly compared to other OECD countries. We're spending a lot more. Having said that, people like spending money on healthcare. Like, if you ask patients, they want more. Absolutely, I want an MRI of my knee and I want another one in 6 months. And so bring it on. So, and this, I alluded to this in my opening remarks about how society has changed from the 1960s to today.
Yeah.
It's not just the age, it's not just the plurality and the diversity, but it's also our approach to purchasing things and researching things and finding out, no, you know what, when I've got a sore shoulder, I can check out online that, ultrasound, yeah, okay, that's kind of old news. That's 20 years ago. I want an MRI and I want it now. Furthermore, if I injured my shoulder at work, my workman's compensation would give me an MRI and they'd give it to me in 7 days. And then I'd see a specialist a day later. So why can't I get that in the public system? So again, patients are smart. And it leads to a comment made in the 1970s by Victor Fuchs, a health economist. He said that no matter how you pay for healthcare, it's always the public who pays. The government doesn't pay, businesses don't pay, the money doesn't come magically from somewhere. And at the end of the day, the middle class especially will pay basically the same. So Zach, you read the numbers out. We might tweak a little bit for the super high end of the income, in the average voter, and then the super low socioeconomic status. But the bulk of voters are going to pay the same no matter how we choose to fund healthcare. All we're choosing is how that money flows. But how the money flows can make a radical difference on how the civil servants, the executives, the administrators, the directors and managers in hospitals run and function. Now, you mentioned about waste, David. So since the 1990s, our approach in healthcare has been to try to do more with less, right? Parsimony. And I think I talk about this in the book as well. So stretch out dollars as far as we possibly can, unless it's a labor contract and we're going to get embarrassed politically. Oh no, pour money there. We'll just fire the new nurses and give a raise to all the old nurses. And then now we've got not enough nurses. So there, it's not always trying to do more with less, but in general, you've got your budget and you're trying to spread it out as thin as possible. What's happened though, and I wrote a piece about this in the National Post, you can Google it. We've actually been providing less care for more spending. So we used to spend something like 8% of our GDP on healthcare in the 1990s. We're now spending north of 11%. After COVID, who knows where we're at? Maybe we're at 12, 13, 14, who knows? We used to, in Ontario, as one example, in the 1990s, we had 33,000 hospital beds. A few years back, we only had 18,000 hospital beds, despite a population growth of 36%. So we are spending more for less care, despite desperately trying to provide more care with less dollars. And so it's entirely the inverse of what we're trying to do.
Let me ask you a question there. Sure. How much of the onus is on the patient? And what I mean by that, and there's no pretty way of saying it, but how wasteful are patients in abusing a system that they perceive as free to get care that they don't necessarily need? So I can even use myself as an example. Based on my own curiosity, I went to my doctor during COVID after I had tested positive on a PCR test, and I said, "Hey, I'd like to do an antibodies test," and she told me no, which was funny. But if I wanted to know for my own personal, just like curiosity. But frankly, I wasn't sick. I was healthy. I had recovered from COVID. I was doing fine. That would have been, in one way of looking at it, unnecessary use of the medical system. So how much of that is a problem? How much are we abusing something good that we have?
Yeah, so great question, and that speaks to my comment about how society has changed. Right, in the 1960s, a lot of people had lived through the Depression and the war years. Use it up, wear it out. Use it or wear. I forget how it's. Use it up, wear it out, to make do or do without. That's how it went, and that's not how we see the world now. Right, those of us born from 1970 and on, or I don't know, you guys born 1980 or whatever. I want to ask when you were born.
92.
But we have a very different. What was that?
89.
There you go.
89 and 92.
There you go. Yeah. So you guys are part of the modern world, and it's like, why the heck would you wear it out, use it up, or do without? No, I've got the funds. Let me buy what I need to buy, and that's the normal way of thinking in the world now. So you asked a brilliant question. All your questions have been brilliant, but I just want to say this one's particularly brilliant because I just wrote a paper on your question, Zach.
Hey, let's go. Make sure you send me the paper so that I can put it in the show notes so that people can read it.
Okay, brilliant. Yeah, I will. And again, it's with Macdonald-Laurier Institute, and it was focused on this issue of user fees. And to be honest, when I started researching this, I was like, user fees, you know what, the system's so hamstrung already, and people have to wait for weeks for an appointment and wait for months for their MRI and wait for months. What the heck's a user fee going to accomplish, right? The wait far outweighs any user fee that you have to face. But your question is about patient behavior, and you're really digging into moral hazard. So in the insurance industry, and they've been dealing with this since the 1950s, how do we deal with the tendency of people to change their behavior when they don't have to pay for the consequences of their behavior? And user fees are common in so we have 28 universal health systems in the world. 22 of those 28 systems use some form of cost sharing. And the insurance industry came up with cost sharing not to raise revenue. And this is a really important point. We don't want to charge patients $5 because the province can't pay for it. Actually, that's been shown to sometimes cost more from an administrative point of view, but also because now you're only seeing the sick patients, which is what you want to get to. So, Zach, you said we have a long line of patients. Some of them are just kind of there because they want to get their antibody titers checked, and they could be in the line or not be in the line. If you charge even a small user fee, $5, the literature is quite solid on this, that people will step out of that line. When they step out of that line, the people who are left are actually much sicker. And so this is a caution that the cost of healthcare per year may go up substantively, because now every single patient you're seeing is like, oh my gosh, they're sick. Yeah, they need to be there. Where the heck's my Zach's asking for antibody titers? That would be easy.
But would those people not be in the line regardless of the user fee? Like, if they're truly sick, would they not already be present in that metaphorical line that we're talking about?
Correct. But they're diluted. Diluted. And so docs talk about cream skimming, right? This is where people hammer on the Shouldice Clinic in Ontario, one of the only private hospitals I'm not sure about Canada, but certainly in Ontario. It was grandfathered in because it had such outstanding results and quality. And so you can still go and pay to have your hernia fixed. Well, people say, well, they're just skimming cream, right? They're taking all the easy patients and they won't take the hard patients. A couple of comments on that is, number one, I think everybody agrees that cream exists. Some patients are easier to deal with than others. Some, they come in, can I have my titers? No, you can't. Go away. Okay, I bill the same for you as I do for David, who comes in with a lump on his shoulder that he hasn't told me about forever. And, he's really, really sick and he's got kidney failure too, or whatever. So not all medical concerns are the same. And not all medical interventions are the same. And so if there's some way, all things being equal, for us to focus our medical funding on those patients who need it the most, I think we'll be doing a better job. There'll be less waits for medically necessary care. We'll be dealing with moral hazard, but we'll also be dealing with this thing known as horizontal equity. So everybody gets excited about vertical equity, right? The rich should pay and the poor shouldn't have to pay because it's not fair. We're going to move that debate to the side. We could have that debate if you want. I think a lot of Canadians agree that, we don't want to see people living under a bridge. We want to help them out. So, but we'll leave that debate. I guess I've already entered the debate. But anyways, if you could put that debate on pause
right.
and then talk about horizontal equity. Horizontal equity is when Zach earns $100,000 a year and David earns $100,000 a year, and you're both twins and you both have the same medical history, the same, genetics, and you both have hip pain. And Zach goes in and says, Whatley, my hip's sore. And we do some x-rays and we say, Zach, you've got osteoarthritis, over the next 5 years, I need you to diet and exercise. If you're fat, your hip's going to wear out a lot faster. Go to physiotherapy, and then we're going to get you a new hip sometime in the next 3 to 5 years. David comes in, identical twin, same genetics. My hip is sore. We do the same thing. You have osteoarthritis. I tell you all the same stuff. And David says, yeah, but I like my Doritos in the evening and I don't want to exercise and I hate physiotherapy. And I'm going to come back and tell you about my sore hip 6 weeks from now. And again, every 6 weeks for 3 or 4 years. So Zach has used up, $100 of the healthcare system over 3 years and maybe only used some Tylenol. David has come in every 3 weeks or 6 weeks. I've sent him to multiple specialists. I've done CT scans, multiple CT scans to tell him what he already kind of knew, but it would be nice to know if my hip was any worse. And at the end of 3 years, David may actually even get his hip replacement, a few months earlier, maybe 6 months earlier. But David has consumed a whack of healthcare resources.
Yeah.
Is that fair? So that's called horizontal equity. And so user fees are a tiny step in the direction towards dealing with moral hazard. Yeah, go ahead.
So actually I have a meeting that I'm now 3 minutes late for, so we have to close her down for today, but
okay.
I can leave. Zach, do you want to keep going?
Yeah, I think we should keep rolling.
Okay, I have to leave, but thank you very much, Shawn. Really appreciated it.
Good to meet you.
Okay, so let's talk about user fees, because that's something that makes sense to me, and it's just simply a barrier to entry thing. Because, I mean, $5 that's a nice thought, but I don't think $5 is going to do it. So let's say it was going to cost me, $100 to go get that test. I'm probably not $100 curious as to whether or not, or as to what my COVID-19 antibody levels are, right? So that's a great step forward. What would be so often when you talk about policy, and this isn't just in healthcare, I've noticed this across anything that we deal with within our country, there seems to be obvious good ideas that never see the light of day. What is standing in the way of something like a user fee being implemented?
So they say Canada is the country of pilot projects when it comes to healthcare ideas. It's very difficult to scale up great ideas. When it comes to user fees, people often say, well, what's the number? Is it $5? Is it $100? All I can say is the literature suggests that small and simple work best. So you're not going to get a bigger bang for your buck going from $20 to $30 or $40 or $50. Most countries that have these use a small fee, but $20 in New Brunswick may be considered very, very high. $20 in downtown Toronto, you can't even get a parking spot for $20. So maybe that's considered very low, or where you're from, just west of Toronto. So that you have to get the number right. It has to reflect sort of what's happening in the local community. And you also have to, Tom Sowell says there are no solutions, there are only trade-offs. And so you have to wonder, okay, what are we losing if we add this fee? The administrative burden. And the literature is also very clear that if you don't have exceptions for the poor, the old, the very, the chronically ill, the very, very young, those user fees end up impacting that end of the spectrum far more. So old people just won't go in when they really need to go in, and very, very poor people won't go in. So every country that has some form of cost sharing has robust exemptions. And I would cut you off there, I think.
No. That makes a lot of sense. So all of these other countries, I think you mentioned 28 other or 28 total socialized medicine examples on planet Earth, right? Is that correct?
Yeah, so this is universal healthcare. And all that means is that everybody can access healthcare. It doesn't mean socialized medicine. So socialized medicine is where the government runs it. And in the show notes, we can put a link to it's the Fraser Institute report that I'm quoting. They just did this recently on the 22 of 28 countries having some form of cost sharing. So it's a great report. I think it's over 100 pages. It's very academic, lots of economic articles quoted in there. And so really, they're the experts right now on the current state of cost sharing globally, at least that I could find.
Okay. So the question is, so there's all these other countries doing something similar. Who should, because I don't realistically see socialized medicine going away within Canada anytime soon. But who could we be taking notes from? Who could we look to as an example who's doing it better than we are? And what sorts of things, because obviously you've invested a lot of time in thinking about this problem, what sorts of things could we glean from other countries who are doing this but doing it better than us?
Yeah, so that's where I used to start this discussion as well. I used to say, okay, let's look at Sweden. What are they doing there? They have a wait time guarantee, whereas if you can't get your hip replaced in 3 months in the public system, then they'll pay for it in the private system, or they'll fly you out of country. That's a great idea. Let's do that. Or they have user fees, but with a limit up to $300. Or they have, so I started looking at all these wonderful ideas around the world, and I think there's value to be had in doing that. The challenge is that every healthcare system is a reflection of the constitutional environment in which that healthcare system exists. So I suspect that Canada will always have some version of Medicare out there. I think if we're going to renovate what we have to start at a more basic level. We don't have to spend hours and hours talking about these basic questions, but I think there are 4 basic questions we have to ask before we start asking about policy options that work well in other countries. And the questions are, number 1, what are we trying to do? What's our goal? Are we trying to redistribute wealth, or are we trying to provide care? So figure out what our goal is. Number 2, and try to agree on that, right? If you sit down with a policy idea with Roy Romano, his first question in his mind is, okay, is this going to compromise the redistribution that we have currently with our current policy? And if it does compromise it, he won't like your policy option, even if it's a great policy idea otherwise. So number 1, what's our goal? Number 2, what's our market? Who are we trying to serve? What do Canadians look like today compared to what Canadians looked like in the 1960s? Canada is a very, very different country. If you were setting up a restaurant or a hardware store, you'd want to know what the people in that community actually want and need. So that leads to my third question. What is the demand? What do Canadians want now? Do they want, is it the wait times that bug them? Is it their ability to choose their own family doc or choose the hospital that they get to go to? So find out what they want. And then the fourth thing is to look at the constraints. What are the peculiar constitutional constraints that we face currently in Canada? It'll be very difficult to say, we want to start from a blank slate. We want to blow up the Canada Health Act. We want to blow up the Medical Care Act. We want to blow up the Hospital Insurance and Diagnostic Services Act. I mean, there's too much to blow up. And even if we blew it all up, rich countries tend to recreate what we already have. And so I think we need to spend a little bit of time looking at the peculiar constraints within Canada and seeing how can we innovate within there. And then we can look at policy options. And when I talk about policy options, I would talk about policy best practices. And for example, governance. We need to know who's the board of directors. Does the board of directors of a hospital actually have control? Or does the Minister of Health have the power to boot out the board of directors and replace them? Does the board have one employee, the CEO? Can the CEO actually make decisions? Or is the CEO handcuffed by, the nurses union and the cleaners union, the CUPE and all the rest, and go from there. How is our governance system set up? We give doctors responsibility, or the opportunity, responsibility, authority to write orders and order tests. Do they have any accountability on the costs that result from that? Do patients have any accountability on the cost that they force doctors to order for them? An MRI of your knee for your anterior knee pain. Anterior knee pain does not need an MRI. Right. But because I don't pay the cost and you don't pay the cost, then neither of us are held accountable for that. So I would start from sort of best practices we see in other systems. I would start with governance if we're at the policy part, and then start looking at, okay, how can we get a pay for results approach? How can we get local decision making? How can we get funding following patients? How can and build from there? Too often we start at the bottom with these policy ideas without talking about those fundamental questions. What are we trying to achieve? Who are we trying to serve? What is it that they want? And what are the roadblocks and barriers that we're going to face in Canada that we're probably not going to be able to change?
Yeah. So is that what the next book is about? Because you mentioned in the current book, only really the last chapter talks like begins to talk about any sort of solution. But you're writing another book then about some of these ideas. How far along are you?
Well, I have around 60,000 words, and they're terrible words, though, right? Every first draft of a book is all over the place. What I'm finding, and I've kind of just laid it out for you, is I thought we could get an approach that would really, fix things. This is the way we should do healthcare in Canada. But as quoting Tom Sowell, there are no solutions. There are only trade-offs. And I mentioned this in the last book, we can't fix Medicare in the way we would fix a flat tire or fix a car that won't start. But we can improve the system we have, or start thinking about other ways to think of providing care. And even getting people to that point where they could consider, okay, maybe funding doesn't have to flow entirely through the public treasury. Maybe we could have a social insurance approach where, okay, everybody has to be insured, but we have multiple insurance companies. Do we really need all that regulation? Why do patients have to go see their doctor before they can get a blood test? Why can't they just go get a blood test themselves? You can buy blood test machines and test your own blood at home. So I think the next revolution in healthcare we're going to see is the technology-patient relationship, as opposed to the doctor-patient relationship being so central. Family docs or GPs are considered gatekeepers in our current system. Other systems around the world don't have that approach. And again, we need to start with, what do our patients want? What do voters want? You want your antibodies checked? Why can't you just go to the lab and get them and say, here's $50, tell me my antibodies. I really want to know my antibody levels. And I mean, I throw these out here for discussion. I'm not saying we have to do that, but we need to at least start having that discussion.
Yeah, I would absolutely agree with you on that. Here's one other thought that I have regarding the whole situation, and it kind of gets outside of medicine and a little bit more into culture. There's a lot of the people who I hear talk about medicine, especially. And I'll say this softly, over the last 2.5 years, there is a suspicion that a portion of medicine profits, and this is maybe toward drug companies more than anything else, but call a spade a spade. Drug companies profit from people being sick. I hear lots of people say it's not the wellness industry, it's the sickness industry, right? Could a portion of the solution be finding ways to actually get people healthier? And I don't mean that by prescribing a drug for a symptom. Okay, so let's say a 40-year-old man has high cholesterol and high blood pressure. You can put him on cholesterol medication. I assume, I'm not a doctor, but I assume, right? This is just for the point of the argument. Or you could advise him to not eat McDonald's every day and to exercise and to take care of his body. Are there ways that we could help Canadians get healthier, because that would just simply benefit them, while at the same time reducing strain on the healthcare system. It's a bit of a different angle at the same argument. You know, these wait times and everyone's overwhelmed and all that sort of thing. But what would happen if we found ways to incentivize Canadians to be healthier? Could we make that part of the solution?
Well, I think we could separate your question into a moral argument and an economic argument. I think the moral argument is, yeah, absolutely. Being healthy, eating healthy, exercising, not smoking, not drinking all the time, it's good for you. So let's try to help you do that. If there's anything we can do to help you do that, great, without, bankrupting the country. To be a little bit cheeky about this, it's always cheaper to not provide care. So if we only focus on economics, the easiest way to save money is to not provide care, and people will pass away on waiting lists or suffer. And that's kind of been, in part, our approach. When it comes to wellness, though, and the pursuit of prevention, so in the late 1970s and 80s, a lot of people argued that we could prevent our way to healthcare savings. It turns out that that's not the case. And the famous example is with smokers. If you tell smokers to stop smoking, they actually live longer. They live longer with chronic lung disease, and they have their heart attacks and strokes. After 15 years, though, it starts to improve, and they will survive longer. But that smoker who you encourage to quit actually ends up costing the healthcare system more overall, because they've lived longer.
Because it takes them longer to die.
Right. Yeah. And so if you don't provide care and say, yeah, smoke your head off, right? And then they die young, well, you've actually spent less. Now, that's a major loss for society. But I'm just saying, if you just talk about dollars and cents, you have to be a little careful. When you talk about the sickness industry, I guess people say, well, medicine should be about health and medicine should be about keeping you healthy. That's a whole actually political push. It's kind of from a public health point of view. Doctors aren't here to diagnose and treat. We're actually here now to educate and motivate and try to get you, we're more like a personal trainer. I didn't go into medicine for that. I actually went into medicine so that I could see sick people and help sick people. So I'm totally okay saying that medicine is about seeing sick people. I think that's why we have medicine. That's why Canadians wanted medical insurance in the first place, so that they could get help when they get sick. So I'm actually very supportive of focusing on trying to help sick people. Now, I know that doesn't totally answer your sickness versus wellness.
I see what you're saying, though. You're saying, yes, it is the sickness industry, but I wanted to get into that industry because I wanted to help sick people. And you're agreeing, but changing the context of the terminology, which I understand and I appreciate. So there,
I was going to say one last thing, though. You mentioned about getting paid for sickness. So George Bernard Shaw, who I disagree with on his politics, he made this point. He said, so doctors get paid to amputate your leg. Well, there's an undue incentive for doctors to take off your leg. Why would you ever want to go to a doctor who gets paid to take off your leg? He's probably going to take off your leg, and maybe you don't want to lose your leg. So he really kind of set the stage for disparaging doctors when it comes to fees for what they do. But we have to be honest and admit, and talk about moral hazard. There's always a risk that if I get paid to do something, I may provide more of that. I mean, that's a reason why we need to really focus on professionalism, medical ethics, and the whole social institution of medicine, where I keep my colleagues accountable and say, Zach, what the heck are you thinking about amputating that person's leg for? They don't need to be amputated. And to say, wait a second, we can't give Zach $1 million for a leg amputation, because he might tend to want to do more amputations instead of trying to do conservative therapy to save the leg. So there are issues there to be discussed for sure, but I don't think it's as simple as George Bernard Shaw would have made it out to be. Yeah,
sure. So not only because, correct me if I'm wrong, the government pays doctors, right? Right. So
totally.
So not only can the patient abuse the system by demanding more care than what they need, doctors can also abuse the system by providing more care than they need to. It can go both ways.
Oh, totally. Totally. And the incentive right now is to avoid getting into medical legal trouble, right? And so if there's a chance that maybe we're going to miss something without doing a CAT scan, you know what? Even if an ultrasound's okay, do the CAT scan. Why the heck would I want to expose myself to medical legal risk? I'm not paying for the CAT scan, and hopefully it's slightly better for you. But that spirals very quickly into, CIHI, Canadian Institute for Health Information, suggested that, and I'm going to get this percentage wrong, I think they said 20%, but it may even be higher than that, of investigations were unnecessary. Now, you could also argue that, well, those are in hindsight. Once you know that there's nothing on the test, well, of course, the test wasn't necessary. But there's this whole issue, to your point, of, where do the incentives lie? Right now, the financial incentives lie toward me actually doing something, and the risk analysis lies towards me trying to order something or pull you back into the office to get you seen. But you're getting into the weeds now of how to pay for doctors. We could go there if you want, but that's really getting in the nitty gritty stuff.
Yeah, no, I don't want to get too far into the weeds. Why don't we boil this kind of back down to what you hope the future for Canadian Medicare is? Like, this is something that you've dedicated a lot of time and thought to, so you obviously have a vision. If you were appointed CEO of Canadian Medicare tomorrow, what direction are you headed? Where do you want to see it go?
So I think we need a bipartisan, left, right, up, down, everyone across the political spectrum, unions, medical associations, public, everybody, to start having a discussion that isn't about protecting their own interests in this one little piece of the pie that we currently call healthcare or Medicare in Canada, right? It's a zero-sum game for anybody to actually admit that maybe we could do something different. So I think we have to start by building a coalition, and it won't be everybody on the left and right agreeing. It will only be individuals. And it'll be individuals in the unions and individuals in the medical association, and try to pull people together and say, all right, this is what we want to talk about. So that's one approach. The other approach is to say, well, we just need more think tanks to keep pumping out pieces, and eventually the public will hear it. That's good. And I'm involved in that industry, and we need to keep doing that as well. I think what you're asking about is, how do we get large scale change? And the ultimate way we get large scale change is that if everyone, so the podcasters are doing podcasts on healthcare, like you're doing right now, that starts changing. That changes one or two people. It makes them ask a few questions. My approach has been, I get asked after conferences all the time, I want to get involved in medical politics, or I want to make change at my hospital. What should I do? And so I push back to the people and I say, well, what do you like to do? Some people like to meet with their MPs. Some people like to write articles. Some people like to do videos and podcasts. Other people like to go to gala events. Do what you like to do, and with a focus of actually influencing change in that environment. So if you like going to galas, go to galas, meet everybody there, and talk to them about wait times. Talk to them about access. Talk to them about hospital overcrowding. Talk to them about, freedom, patient freedom, and nursing freedom, and physician freedom. And so figure out what you like and where your interest lies, and then use your skills in that particular area. And I think that's where we'll get change. I'm much more skeptical about sort of someone coming in with a singular movement, and we're just going to, those of us who land right of center too often think that, we just need the government to make a decision, or we just need AHS to be obliterated, right? And we can start from scratch with our own thing. I'm not sure that will do it. I think I put more faith or hope. I put my money on individual people pursuing things that they actually like in this niche we call healthcare, learning about it. There are no experts here in this industry. And so jump into it. When you talk to an expert, they'll be an expert on economics, or an expert on the legal issues, or regulatory reform, or hospital management. Doesn't mean they're an expert on everything. Philosophy of medicine, social anthropology. I mean, there are so many areas where you can dig into. So just find the one little niche that you like, become a micro expert on that area, and then just go make friends. If you make friends writing letters, write letters. If you make friends doing podcasts, do whatever it is that you really like doing, and it'll come across as being very authentic, and you'll be influencing a few people at a time and empowering them to ask their own questions and become their own experts. I think that's what's necessary to create a base so that this healthcare conversation doesn't fall on deaf ears, or people say, whoa, what are we talking about? I've never heard that before. No one in my community is talking about that. Well, we have to do that background work of, I hate to use the word socializing the idea, but we have to get ideas out there before we can start putting them into political campaigns.
Right. That makes sense to me. Okay. I have one more question for you, because I would be remiss to get the opportunity to speak to a doctor and not bring up COVID. So if you don't mind, as someone who is practicing, who I'm sure if you have a practice, I'm sure you saw plenty of people who had COVID. What is your take on, I mean, it's a big question, but what is your take on everything that went down in our country regarding COVID? I'll say this. To me, it feels like, from my perspective, from someone who's not involved in medicine, it looks to me as if the people who were actually boots on the ground were always like just doing the best that they could and trying to help. And I have massive amounts of respect for them. But I also feel like there's this other portion of people who saw an opportunity to move forward very controlling measures for the purpose of, I don't know, political or financial gain. So I don't want to disparage medical professionals. I'm not saying that, but I feel like some weird stuff went down in medicine over the past 2.5 years. What is your take on it as someone who was right there seeing patients?
Yeah. So we have another hour to discuss this, right?
Yeah, maybe.
Yeah. So I was actually, in the final drafts of my book when COVID hit in spring 2020. And I was actually blogging about this in February and saying, hey, people, there's this really bad virus in China. Maybe we should pay attention to it. We already have hospital overcrowding. What the heck are we going to do? The week before Canada declared a pandemic, the largest hospital in Brampton, which, Brampton, Southern Ontario,
yep,
they declared a state of emergency. Unanimously voted to declare a state of emergency at the Brampton Town Council for hospital overcrowding. The very next week, we declared COVID. And so I had been blogging and saying, listen, people, even a bad flu season shuts down hospitals. We've got this thing called COVID coming. At the very least, are we ready for it? Do we have supplies? Do we have PPE? Or are we sending 16 tons of it to China like the federal government did? However, within a month of lockdowns, and I supported lockdowns at first because we didn't know what was happening. We didn't know how to treat the illness. We didn't know who was going to die. We didn't know who was going to get sick. But by April, May, and I blogged about this too, I said, time to end the lockdowns. I've got people coming into my office, or I'm talking to them on the phone, and they're too scared to go to the hospital. And they're basically going in when they go to emergency straight to ICU because they're so sick. They tried to do, whatever they could to avoid the hospital. So COVID still represents a tiny fraction of the medical burden that we have to care for in medicine. And so we weren't seeing the cancers. We weren't doing the screening. We weren't seeing the bladder cancer. Pick something that's not too exciting and doesn't make it to the headlines. Diabetes care, skin care, checking for skin cancers. And there's a million things that weren't happening because we were only focused on one risk. And again, a shout out to MLI. They did the COVID misery index and they updated it a few times. And they looked at public policy options chosen by countries around the world. And it turned out that the Canadian approach was far more draconian than anywhere else in the world, and without outcomes to match that strong public policy approach. Now, the one area where we can still get agreement on this, abnormally authoritarian approach is people say, yeah, well, our healthcare system was so bad, we had to do it. We had to tell people to stay home. I still debate that. I think 2 years, certainly 6 months into the pandemic, a year into the pandemic, there's no excuse for saying, oh, we don't have hospital beds. No, you've shown that you can build military hospitals. So I wrote an article in the Toronto Sun criticizing Premier Doug Ford for, he added a few beds to hospitals, but we were still saying, oh, this is bad. COVID's here. We don't have capacity in our system. Garbage. This is your job. Like if you're saying we don't have beds and we're in a major pandemic and you're shutting down how big is the economy in Ontario? Is it 30 billion or 100 billion? Anyways,
I
billions and billions.
Of my head, yeah.
Yeah, I forget the figure and I apologize that I probably have it written down here in my notes somewhere. But a multi-billion-dollar industry shutting it down to protect the healthcare system that, well, why don't you build more hospitals? And they say, well, we don't have nurses or doctors. Well, I'm sorry. I didn't see very many emails coming out asking doctors who had just retired or who weren't working full time to come back and help, or nurses who had retired and come back and help, because there's so many people in the hospital. A lot of the early COVID phase, the hospitals were empty. There were tumbleweeds blowing down. You could throw a bowling ball down the hall and there's nobody there because everybody was out. The hospital had been shut down for this swell of COVID patients that actually never showed up. So there's so much that we could talk about here. In fairness, people didn't know how this was going to go. We didn't know. Maybe this was the end of the world. Maybe that this was the only policy approach we could take. But we're starting to see data roll in now that the policy approach we took was, way out of line. And a number of us were raising alarm in advance. I don't want to dismiss that this virus can kill people, and it tended to make old people very, very sick. And I've lost some of my own patients because they got sick. Many of those patients may have died from influenza in a different year. But it was even over and above influenza. But unfortunately, it became so politicized. It's either you're a COVIDian or you're a COVIDiot, right? And it's just like black and white. This is a failure of political management and governance, in my opinion. You can't abrogate your mandate as government to a bunch of public health experts. Your job as government is to listen to the experts, and then listen to the economists, and then listen to the public relations people, listen to the labor relations people, listen to the sociologists, listen to the clinicians, and weigh all these risks and benefits and come up with an approach that will, try to maximize health, but also minimize harm to health from all these other risks that are associated with lockdown. I mean, you talk about if people are in an unsafe environment and they're told now you have to be in that house 24/7 with someone who is unsafe to be with. I won't go into details of what I mean by unsafe, but you and your listeners can figure out all the different ways that it's unsafe. And sorry, go ahead.
No, I was just saying, I understand. Something I love to bring up is that Stats Canada themselves published that lockdowns killed more people under 60 than COVID did. And you're bang on. When the first lockdown, I mean, people know me if they listen to my show. I've been very against a lot of these measures for a long time. But I'll say it again. Back at the first one, when we had no idea what was going on, when it was 2 weeks to flatten the curve, I was right on board. And I mean, like, selfishly, I had been working really, really hard. I had been traveling a whole bunch because I used to travel a lot for work. And I was like, man, 2 weeks at home would be great. Like, I'm into it. And if we can like save a whole bunch of people's lives by me sitting on my couch, like, let's go. That sounds great, right? I had no problem with it. But you're right. Information changed fairly quickly. And I always talk about the open letter Roman Baber wrote to Doug Ford talking about case fatality rates. And I looked at my demographic, like my age group, and I went, okay, like 0.004 or something like that. And I went, that's certainly different than what we were told. And that isn't to say, like, I still, like, if it had just kind of cleaned up then and there, it would have been like, no harm, no foul. That's great. We're figuring stuff out. But you're right. I think that there was a abdication of responsibility on on the part of some of our leaders, because you said the right thing. There, if you're leading a nation, a province, whatever it happens to be, you're supposed to consult experts. So yes, consult the health experts, and then consult the economic experts, and then consult the social experts, and then continue to consult as many people as you have to consult. But ultimately, as the leader, you have to make a nuanced decision that supports the overall bird's eye view of what's happening in whatever you're leader of. And that didn't happen. We just abandoned ourselves to health experts who, of course, are going to say we should do everything that we can to make sure that we can keep people healthy, which is their job, you know? But it got really out of balance. So in light of everything that's gone on with vaccination, and I don't know if you saw it, I don't know if you saw the news out of the Dutch Parliament where they were talking to an MP was talking to a member of Parliament, or not a member of Parliament, an executive from Pfizer, who said, they didn't test as to whether or not their vaccine would stop transmission before rolling it out. But it wasn't their fault. They had to move at the speed of science. So maybe I'm just too dense and dull and uneducated, but I've never heard of the speed of science before. I didn't realize it was a unit of measurement. Could you explain that to me by any chance?
Yeah. Well, I'm too dense too, and I can't figure that one out. For me, and I was on the radio with I won't say who the host was in Ottawa, and it was about a piece that I had written for the National Post saying, it's time to start living with this, and we need to sort of get moving. And I was a co-author on the piece. And so he started attacking me that I wasn't pro mandates and vaccine mandates. And so I wasn't supportive, and I was heartless and all the rest. And I said, listen, I've actually had the vaccine myself. I encourage people to consider it. My experience at the bedside is that you get far more accomplished when you actually listen to people and try to build a relationship and ask them, okay, you don't want to give your kids vaccinations. Why is that? What are you worried about? Okay, well, my friend told me about the study. Can I see the study? Let's have a chat. Let's look at the study. And so you have to build the relationship to actually talk about it. And this applies far more than to just vaccines. So someone needs to lose weight, or they're having trouble quitting smoking, or they need to stop drinking. And you talk to them and say, very few people drink as much as you do. And no, doc. Yeah, me and my buddies, and so you've got to try to build some rapport with them, because there's going to be 100 other things that they're going to need to trust you on once you actually help them to make the decision to decrease drinking. And so I talked with the host about it. He did a 180 flip on the conversation. He said, doc, both my parents were alcoholics. Both of them died of liver failure. They're heavy smokers. And I can tell you, you're right. They know people can't change what they're doing when they're, and he went on a big long rant. And I said, that's my experience. I mean, you've got to come alongside people who are worried about something, figure out what they're worried about, try to help address their worry, but force does not work. People find a way around the rules. If they're worried that putting something in their body is going to cause major problems, they're going to be very, very seriously worried about it. On top of that, though, you had the CPSO in Ontario saying that you're not allowed to, have any, create any kind of questions around the COVID vaccines and the rest. And I wrote an article for the Sun and said, the CPSO wants doctors to shut up. That approach doesn't work. I mean, what we do in medicine is we say, okay, you should get a colonoscopy, so a camera up your bum looking for colon cancer, but it could cause bleeding. It could put a hole in your bowel. You could die from this. You could have permanent strictures, like could have an infection. You could end up in the ICU, but it's a good idea. You should go do it. So our approach is always to tell you all the worst possible things that could happen. But by the way, it could save your life. We weren't allowed to do that with COVID vaccinations. We weren't allowed to say, hey, you know what? This is a really rapidly developed experimental vaccine. Yeah, awesome. I'm so glad they developed it. However, we should still be, maybe let's keep our eyes open. And, what's your individual risk, Zach? Okay, it's pretty low. Why don't you wait for 6 months and take it then? We couldn't have those conversations. It was just, I was told I had to say whatever public health said. And that's what I would tell my patients. I would say, listen, I've been told by my regulator that I have to follow what public health says. That's not medicine. And patients can see through it. They can see it in your eyes. They can see that, you know what, that hasn't been my approach ever with my doctor or any doctor. They always tell me all lists of things I should worry about. And now this one particular medical intervention is good because public health says it's good. So I think we've lost public trust. It's going to take potentially decades, maybe some people, certainly in your generation, who really had, virtually non-existent risk from the disease, being forced to do something, not able to travel. Their tea shop in their local town is now, that they're put out of business but people can go to Walmart or a big box store and buy the same products. How is that fair? I mean, there are so many layers of problems. It grieves me. The whole thing grieves me. It didn't have to be this way.
Yeah. Yeah. And it's not necessarily the fault of someone like you, the physician, right? It's a decentralization problem. It's a centralization problem. It is from the top. This is what has to happen. Shut up. Don't ask questions. This is how it goes. Go. And that, I don't think that ever works the way we want it to work. Here's a question. When you first started, like at your clinics, first started getting doses of the vaccine, what information as a doctor were you provided with about efficacy and safety? And did that differ from other drugs that you had seen go across your desk?
So when it comes to vaccination and vaccination clinics, the province tended to take over the whole thing, right? We had COVID vaccine clinics. And so all of the information flowed through there. The booking flowed through there. Tracking flowed through there. I actually didn't personally work at a COVID vaccination clinic. A number of my colleagues did. There weren't a lot of patients, and they actually paid docs an awful lot of money to sit there doing nothing for a lot of the clinics. Now, having said that, I mean, kudos to people thinking that, okay, vaccinating everybody is going to help us, so we need to put this infrastructure in place. But, and I think there's going to be a lot of questions asked after the fact, just like you're asking now. How much did we spend? How much was this necessary? What were we trying to achieve? Did we have good information to make these decisions on? Unfortunately, it's kind of like analyzing a war after the fact, and whether or not you should have charged up the slope or jumped out of the ship or the airplane. So I want to be a little bit differential to the people making decisions. Having said that, I totally get my patients and my friends saying, this is nuts. Like, what the heck's going on? And so I understand that end of things too. I guess I'd close with this comment. In the first year of the pandemic, there were over 200,000 scientific articles published. This is according to Nature magazine. Nature is a scientific journal. Over 200,000 scientific articles published just on COVID, the treatment, how it seems to work, the nature of the virus, and so on. You would have to read all day long just journals, and you'd still wouldn't be able to keep up by the end of the year. And that was just in the first year, and the first year wasn't even a full 12-month cycle. So what has happened is we have this flood of data and information and attention, a lot of it driven by the media, on one virus. No one can keep up with all of it. And yet we're getting further and further and further into these details, and no one is sort of stepping back and trying to look at the forest. We're just all focusing on the trees. And I think bad things happen for individual patients, bad things happen from a policy perspective, bad things happen from economic decisions being made on how to allocate funding, whether we do it to cancer screening versus a COVID clinic. I really hope that we get an opportunity to debrief and review, how did this happen? Like what sort of decision-making process failed, or what worked well? Maybe some things did work well, and let's focus on those too.
Sure. Yeah. It would be interesting to compile a whole bunch of doctors and policymakers and whoever else has to be involved, and sit down and say, okay, let's dedicate 6 months and just, how did we do? so this thing happened. How'd we do? How'd that go? That would be an interesting thing to kind of try to pick apart. And I think there could be a lot that we could learn from that. But I don't want to keep you any longer. This has been an incredible conversation. Please, everyone, if you're interested in the future of your country, if you're Canadian, go get this book. It's our responsibility to understand what happens in our own country, and not paying attention to it doesn't work. So put the onus on yourself. Give yourself a little bit of an education. He wrote a fantastic book. It's incredibly well written. It's very cited, which I love, because I love the idea of being able to back up what you're saying. And get involved and just start thinking about some of these things. So thank you for writing the book. Thank you for coming on the show. And what's your timeline? When's the new book come out? I can't wait to read it.
Yeah, so great question. I should get something out, I hope, over the next year. The biggest part is, making sure that you get an arrangement with your publisher or a publisher, whether they want to do it. There's not a huge market for healthcare books. So I really appreciate the shout out. I mean, you guys asked, both you and David asked really, really insightful questions. And this kind of topic really needs to, to have the hour and a half podcast to dig into. And even there, we were dropping some topics and scooting off to other topics. So I really appreciate what you're doing here, and a shout out for your podcast. This has been really enjoyable. Thank you so much.
Well, thank you so much for coming on, and I hope we get to do this again soon.
Thank you for listening to The Canadian Story. You can find us on Instagram and Twitter at The CAD Story. That's The CAD Story. If you enjoy this podcast, please share it with your friends and family. Let's work together to remind Canadians how great their country is.